Good evening, everyone. I think we'll get started. My name is Roberta Sterling. I am the clinical program manager for the Smilow Cancer Hospital Care Center in Torrington. I want to welcome all of you to tonight's Smilow Shares programming, highlighting our multidisciplinary breast cancer care. Before the program begins, I just want to talk about one housekeeping item. We want to be sure any questions that you have during the presentation are answered. We have allotted time for that at the end of each segment that will be presented. You can use the question and answer section or the chat function on the bottom of your screen to type in your questions, and we will make sure that they get answered. And now I'm going to hand it off to Dr. Talsania to do more of an introduction to our program. If you indulge me for a second while I share my slides. Dr. Talsania, can you see?
Thank you. Thank you, Roberta. So thank you everyone for joining us this evening for Smilow Shares in talking about breast cancer. This is our team in Torrington. Go to the next slide.
Technical difficulties, hold on. There we go.
So today I'm going to review what Torrington Care Center has to offer. I'm going to introduce the panelists besides myself, followed by a presentation on breast cancer, and then time for question and answer session. So I'm Dr. Talsania. I'm one of the assistant professor of clinical medicine in medical oncology and hematology. We have Dr. Greenup, who's a chief of breast surgery at Yale New Haven. And we have Dr. Lustberg, who's a chief of breast medical oncology at Yale New Haven, who will be joining us as well. And Roberta, as you've met with her, she's a clinical program manager at the Torrington Care Site. So our vision as part of the Yale Cancer Center is a world leader in cancer care, research, and education. We want to deliver the transformative scientific discoveries and care and innovation to bring closer to a world free of cancer, and we take care of one patient at a time. Our mission is to provide expert, evidence-based, and compassionate care to patients and their families. We conduct basic and translational research to advance diagnosis, prevention, treatment, and cure of our patients. We also design programs that promote public health, particularly among patients who are high risk and underserved population. And we want to disseminate innovations throughout the world. And we're also training a next generation of leaders in cancer care and research. So as you see in the pictures, the red stars basically depicts the cancer centers that we have throughout the state of Connecticut. Our aim is to have Smilow centers within 30 minutes of your home. As you can see, we have about 15 care centers across Connecticut. We are provider-based. We have Yale Cancer Center physicians as well as Smilow employed staff. We have uniform policies and procedures throughout the care centers. We have quality initiative projects, and we capture about 48% of newly diagnosed cancer patients throughout the state. At Yale Cancer Center, we provide the state-of-the-art clinical care with aim to have ongoing growth in patient volume. We have faculties who are recognized as national and international leaders in cancer care and research. We have outstanding records of research that spans the breadth of investigation. And we have cutting-edge program trying get in clinical trials. And we are leading in developments of new therapies across the spectrum of cancer. So this is a little bit about Torrington and about the program that we have at Torrington site. We integrated with June in June of 2012, so it's been 10 years. Our local hospital, Charlotte Hungerford Hospital, we have about 13 infusion chair and 1 bed at our care centers. We have 4 physicians, 1 oncology trained APRN, and a village. As you know, it takes a village to take care of a patient. We have access to national clinical trials, to specialty tumor boards, and we also have access to support programs like medication assistance, tobacco cessation, genetic counseling, palliative care, survivorship, and integrative medicine, through which we have now, given the current situation, we have online support with yoga, meditation, and chair-based exercise therapies. This is our current staff at the Torrington care site. I have Dr. Harvey, who's the medical director. We have Dr. Alsop, and we have Sarah Thurman, who is our oncology trained APRN. So it takes a village to meet with our special needs for our patients. And we have the physicians and the nurses, as I talked about. We have oncology certified nurses, nursing coordinators, and practice, as well as infusion nurses. We have oncology trained pharmacists and pharmacy technicians. We have clinical research staff, trained lab technicians, ambulatory care associates, as well as the medical record staff. And for the supportive care, we have on-site social worker, nutritionist, genetic counselor, and palliative care specialist who visits our care center for the needs of a patient. So this is some of the amazing staff that we work with on a regular basis. And this is how our care center looks like from the outside. So I would now pass on and hand it over to Dr. Greenup, who will take us through her slides.
Well, thank you for the opportunity to speak tonight. Can you all see my slides? So I'm going to do a brief overview of updates in breast cancer surgery. My name is Rachel Greenup. I'm an associate professor of surgery at Yale and the chief of breast surgery. I've been at Yale for over a year. So many of our patients come to us having been diagnosed with breast cancer based on abnormal imaging. And you can see here a picture of a diagnostic mammogram showing a spiculated mass, followed by an ultrasound and a biopsy showing breast cancer. And any discussion about breast cancer surgery needs to include the importance of breast cancer screening and the controversies that have surrounded this initiative over the past decade. There were a lot of controversial discussions and disparate beliefs about breast cancer screening. The U.S. Preventive Task Force first came out saying that women under 50 could potentially avoid annual screening mammogram, and that this should be an individual decision and take patient context into account, recommending biannual or every other year screening for women over 50. And leaving the annual imaging of women 75 and older as a black box, recognizing there was insufficient evidence to make a recommendation. And one of the most controversial topics that were brought to light in these guidelines was that the U.S. Preventive Task Force recognized that there was no benefit to clinical breast exam, although we still encourage our patients to perform one, knowing that we meet many women who identify their own breast cancer. The American Cancer Society guidelines then came forward showing that women 40 to 44 should have a choice to start annual breast cancer screening with mammograms every year, and that risk be taken into account, including family history. They recommended that women 45 to 54 should get mammograms every year, and that women 55 and older could consider every other year. In 2019, the American Society of Breast Surgeons came forward with a position statement that really accounted for age, risk, and family history, with the addition of supplemental imaging. So they included that women aged 25 and older should undergo formal risk assessment for breast cancer. And many centers are thinking about doing this as part of their screening efforts. They also recommended that women with average risk of breast cancer should get annual screening starting at age 40, and that those with higher than average risk undergo screening mammography with ultrasound and/or MRI. And overall, that when life expectancy was less than 10 years, annual mammogram could stop. One of the most important parts of the ASBS recommendations was recognition that women with dense breast tissue might need supplemental imaging. The ASBS guidelines recommended 3D mammography or tomosynthesis for women with higher breast density and recommended the addition of supplemental MRI as a potential modality. One of the things that I love most about my work is looking at where we've come over time. So when we look at the past, women who had breast cancer 50, 60 years ago, excuse me, underwent radical mastectomy with removal of the pectoralis muscle, including extensive lymph node dissections of their axillary nodes and even their internal mammary nodes. And that stopped when breast cancer surgeons recognized that lumpectomy with radiation was equally effective. We also have reduced the number of full lymph node dissections that we've done with uptake of the Z11 guidelines. This was a study published in 2011 showing that women with 1 to 2 positive lymph nodes could forego completion dissection in lieu of radiation therapy. We've cut back on the amount of radiation we've done in women over 70 with hormone receptor positive favorable breast cancers, according to the CALGB 9343 trial. Systemic therapy decisions are now routinely guided by tumor biology, with results of the TAILOR-X trial prompting further reductions of chemotherapy. And the ongoing COMET trial is looking at which women with DCIS can forego active surgery plus radiation in lieu of surveillance. So as many of you know, women come to meet us with a new breast cancer diagnosis, and my job as a surgeon is to discuss their options for surgical therapy. We often discuss with them the need for mastectomy versus the choice for lumpectomy. We discuss axillary staging or lymph node management. We review options for reconstruction, and we talk about the other breast. Historically, to do a good lumpectomy, we relied on the wire placement, and now we have new localization strategies, including radioactive seeds or tag seeds, which is a RFID technology that we've employed across the Yale sites. This can go in anywhere from 2 to 5 days in advance of the woman's surgery. It's much more comfortable for patients to not have a wire sticking out of their breast. They can uncouple surgery from their localization procedure, meaning that they can then be first start in the OR that morning and be done with surgery sooner, which allows them to get home and have something to eat or drink. And the data is very promising that this is associated with higher patient satisfaction, improved margins, and smaller resection of tissue. When we remove the lumpectomy tissue, whether it's through use of a wire or a radioactive or tag localizer, we image the specimen in the operating room to make sure that we've removed the mammographic finding, the tag, and the biopsy clip. And there's been a lot of controversy over the past few years about margins after lumpectomy and how much distance is enough. We know in the past that re-excision rates after lumpectomy were associated from 15 to 25%, meaning that 1 in 5 women potentially were going back for a second surgery to take more tissue, and that almost half of those patients were re-excised for close but negative margins. We know that positive margins after lumpectomy was not very accurate in predicting the residual disease in the breast, and there was a clear lack of consensus with wide variation in clinical practice. And this is one of my favorite illustrations. This is a pathology slide showing that in the same tissue block, deeper levels showed that the cancer cells were at least 2 versus less than 1 millimeter from the inked edge. And we know that women's local therapy is dependent on the pathologic review, which is part of why it's so critical we have excellence across our multidisciplinary team. In 2014, there was a consensus statement pushed forward by the Society of Surgical Oncology and the American Society of Radiation Oncology, bringing together experts across the fields to develop guidelines on margins for breast conserving surgery in women with early stage invasive breast cancer. And these efforts were led by one of our Yale radiation oncologists, Dr. Maryam, and these were really practice changing. They reviewed about 33 studies, which included over 28,000 patients, showing that positive margins were not acceptable, meaning that women with truly positive margins need to go back for re-excision. but that no tumor on ink was an adequate negative margin, and that further negative tissue or further margin width did not decrease in breast recurrence. Similar analysis was done looking at women with ductal carcinoma in situ. This was a smaller cohort of patients, same number of studies. And with DCIS, paradoxically, the guidelines recommend that we do aim for 2 millimeters of healthy margin to reduce the risk of in-breast recurrence, likely related to the pattern of disease that DCIS displays under the microscope. Then in 2015, a randomized controlled trial, again led by Dr. Anis Jagpar at Yale, published in the New England Journal of Medicine, showed that additional cavity shave margins going back at the time of lumpectomy to take thin layers of the cavity walls was associated with reductions in the need for re-excision. This showed that it reduced the positive margin rate significantly by almost half, and women required less second operations after lumpectomy. When I think about mastectomy in 2022, there continues to be a patient request for bilateral mastectomy, double mastectomy, or what we call contralateral prophylactic mastectomy. We know there's no medical evidence that this is associated with either an oncologic or survival benefit, and that there is an increased risk of surgical complications, but patients do request this for surveillance, improved symmetry, and peace of mind. There's been discussion in the lay press about Angelina Jolie's influence over the rates of CPM. And so the American Society of Breast Surgeons came forward with clinical guidelines in 2016, recommending that prophylactic mastectomy in average risk patients not be done routinely, and that a bilateral mastectomy may improve cosmetic results, but the rate of contralateral cancer remains quite low, especially in women taking endocrine therapy, averaging between 0.1% and 0.6% per year. I've had the opportunity to train with and learn from experts in nipple-sparing mastectomy, and there's, again, great controversy about who should be a candidate for nipple-sparing procedure. Things to consider include distance from the nipple to the cancer, significant ptosis, and the ability to reconstruct the implant breast or the autologous tissue breast mound, making the skin envelope in the nipple in an acceptable aesthetic position. If the quality of the skin is poor, if women have very large breasts, or if there's a broad area of DCIS, those are things to consider. True contraindications to nipple-sparing mastectomy includes clinical nipple involvement. So anytime I see a patient with bloody nipple discharge, nipple scabbing concerning for Paget's, nipple retraction, or skin thickening, I do not recommend this operation. If they have radiographic concern for nipple involvement demonstrated in the MRI here, or if they have a positive subareolar margin based on the surgical pathology. Again, locally advanced or inflammatory breast cancer remain contraindications for both nipple-sparing mastectomy and skin-sparing mastectomy. This was a nice prospective study published in JAMA Surgery. I had the opportunity to participate in at my last institution, and it included 9 institutions of almost 550 risk-reducing mastectomies in women with known BRCA1 and 2 mutations. The median follow-up was 34, then 56 months, and it showed that there was safety in offering nipple-sparing mastectomy, at least in the short term. And lastly, this is older data, but remains critically important, showing that in women who have known BRCA mutations who then develop breast cancer, lumpectomy and radiation may still be a feasible option, although these women have a significantly higher risk of both an in-breast and contralateral recurrence. Yet it does not impact their overall or disease-free survival because they're being surveyed so closely, and their systemic therapy and oophorectomy reduces their risk. If you get a group of breast surgeons in a conference room, the most controversial discussion is around management of the axilla, and we continue to learn and grow, and occasionally our clinical practice outpaces our research findings. The ACAZOXY 11 trial showed that not all positive sentinel nodes warrants axillary lymph node dissection. This trial looked at women who had 1 or 2 positive sentinel nodes who were undergoing breast conservation and showed that completion lymphadenectomy or completion axillary surgery was not necessary, knowing that the radiation to the breast in women after lumpectomy likely covers their lower level axillary nodes. Similarly, the Amorose trial, which was a radiation trial, showed that axillary radiation was as effective as axillary lymph node dissection. This study included almost 5,000 patients with 6 years of follow-up and showed that although about a third of women in each arm likely had additional nodal disease, axillary occurrences were very low, and that axillary radiation was as effective as axillary dissection without the morbidity of lymphedema. The Alliance 11202 trial has almost nearly completed accrual, but we'll await these data. This is a very important study looking at women who have positive lymph nodes before neoadjuvant chemo. They go on to have breast conserving surgery or mastectomy. If their sentinel lymph node is positive, they get randomized to axillary lymph node dissection plus radiation, or they get randomized to no further axillary surgery, relying on radiation to treat the nodal disease. The sister trial to this is the B51 study, showing that if women convert their previously positive lymph node to a negative node after chemotherapy, they could have regional nodal radiation or no regional nodal radiation. And we await the findings from these studies, which will certainly be practice changing. Genetic testing in 2022, again, we're learning constantly. The NCCN guidelines expand all the time. In general, it's women diagnosed with breast cancer less than 45 years, women less than 50 with a family history, 2 breast primaries, women with triple negative breast cancer, and that has recently expanded to women with any age at diagnosis of triple negative breast cancer, and then a personal history of ovarian, male breast cancer, or pancreatic cancer. Again, there's been some discussion about whether we should offer hereditary cancer screening to all breast cancer diagnoses. This was data from Dr. Peter Veitch suggesting that we were missing a significant amount of women who might have hereditary cancer syndromes, that if we don't test women outside the guidelines, they have an opportunity for positive results that may have implications for their care. So as a result, the ASBS again came forward with clinical guidelines for our membership, recommending that genetic testing be made available to all patients with a personal history of breast cancer, and that women who've had prior genetic testing may benefit from updated testing. We know that insurance coverage does impact women's choice for testing, but rates of out-of-pocket costs have dropped to about $250 for many patients. And then lastly, when we look at women who are high risk outside of hereditary cancer syndromes, there was great data at our recent San Antonio Breast Cancer Symposium suggesting that low dose tamoxifen might be very effective in women with high risk lesions, including DCIS, LCIS, and ADH. That at 5 years, there was a reduction in their risk of cancer development, but with a lower major adverse effect and lower side effect symptoms from menopause. Lastly, I'd like to touch on surgery in women with stage 4 breast cancer. In the past, this was done to prevent a local problem for wound control or relief of symptoms. But more recently, we meet women with stage 4 disease who present with operable breast cancer. They're healthy at diagnosis. We're finding this asymptomatic disease on modern imaging, and we have wonderful improvements in systemic therapy. So their survival is improving. In the past, there was a long list of studies that suggested that removing the primary breast tumor in someone with metastatic disease was life extending. But the findings from the ECOG 2108 trial, led by Dr. Seema Khan at Northwestern, suggested that surgery and radiation did not extend survival in women with newly diagnosed metastatic breast cancer, that their quality of life was the same, but it did improve the risk of the tumor growing to become a local problem. I think the last thing I'd like to touch on from a breast surgical perspective is our recognition that we're responsible for the amount of opioids that are being put out into the community. Breast cancer is a common diagnosis. A lot of women have breast cancer surgery, and we know that a lot of people who undergo surgery are exposed to narcotics that then can go on to become addiction. About 71% of users receive opioids via diversion. So this is an important topic of conversation for our surgical community. We know that breast cancer patients are not immune from narcotic use, and this is a study done by my colleague, Dr. Leslie Dossett at University of Michigan, showing that breast cancer patients who especially undergo either neoadjuvant or adjuvant chemotherapy are at higher risk of opioid use long-term. And lastly, these are nice guidelines from the Michigan Cooperative Group showing that when we're doing breast cancer surgery, we should aim for opioid-free surgery or low doses, including 5 to 10 tablets of oxycodone with lumpectomy and between 10 and 20 for mastectomy. So I'd like to thank you for your attention, and I'd be happy to take any questions.
There was a question in the chat. If you could please explain what you meant in relation to no benefit for clinical breast exams.
Yeah, so that's a great question. So the U.S. Preventive Task Force guidelines put forward a statement showing that there was no evidence-based benefit to women doing self-breast exams. And that was obviously very controversial because we had spent significant amount of effort teaching women how to do self-exams, handing out cards that women hung in their showers. And they came forward basically saying that the data did not support that clinical breast exam saved lives. Now, women ask me about this in the office. I still encourage them to get to know what their breasts feel like. It can be very hard, especially for our breast cancer survivors who have lumpy, bumpy breasts, to know what's normal, what's not. The monthly breast exam makes sense. If you see a child every day, you miss seeing them grow. So you want to have a little difference between one exam to the next to know if something's changed. But we still meet a lot of women who either find their own breast masses or whose spouses or partners find their breast mass.
And there is a relatively detailed question in the Q&A. I'm not sure if you can see it, in relation to an individual and family history that I'm thinking might be more appropriate when we share the email at the end of the presentation, that individual can email directly and we can get the best appropriate answer.
Yeah, and I'm happy to just paraphrase, but essentially it's a patient with significant breast cancer whose BRCA testing was negative, but there's obviously something going on in that family. The patient had advanced stage 3 breast cancer diagnosis. Her sister had breast cancer. Their maternal aunt had breast cancer that metastasized and died. And what should we recommend for her daughters? We typically suggest that our patients' family members undergo breast cancer screening approximately 10 years younger than the earliest age at diagnosis, either mammogram and or supplemental ultrasound with MRI, and that would be supported by the ASBS guidelines. So from an insurance or payer standpoint, there should not be pushback about starting surveillance imaging in these above average risk women. And I do say pretty regularly to my patients that we meet a lot of women with significant family histories that we never detect a gene in, but it doesn't mean that their risk is now average. And we are always happy to see these patients at our breast center. We have a robust layer of APPs, and we have a growing high-risk program to absorb these women that we know need a medical home for their breast care.
Those are all of the questions that I see so far.
Well, thank you. And feel free to email us anytime. It's rachel.greenup@yale.edu, and we're happy to support you in caring for our patients.
I think we can have Dr. Lustberg now present her part of breast medical oncologist, and I would let Maryam take over.
Great. Thank you. Thank you to all the audience members for joining in. And so my role tonight will be to give you an update on the latest in breast cancer medical oncology. I will emphasize a few of the themes that Dr. Greenup referred to, because ultimately breast care is a very multidisciplinary specialty. And prior to the 1970s, we used to think about breast cancer as one disease. And then we have learned a tremendous amount in recent years, including the discovery of the estrogen receptor. And we have learned how to block the estrogen receptor with drugs such as tamoxifen. So this was a huge advance in how we treat breast cancer. And a number of anti-estrogen therapies were used. And then subsequently, we discovered another important target called HER2. And again, by being able to target the HER2 pathways with HER2-directed targeted therapy, we essentially have revolutionized how we treat HER2-positive breast cancer. So the main take-home message for you is that not all breast cancer is the same. And if you are currently diagnosed with breast cancer or are a breast cancer survivor, I think it's important for you to know what type of breast cancer you had. And broadly, there are three big categories of estrogen receptor positive disease, HER2 positive disease, or triple negative. However, even these broad classifications can be further broken down. For example, the ER positive variety can be broken down into the more slow growing luminal A versus a faster growing luminal B. And even our triple negative tumors can be a heterogeneous group of breast cancers. So the subtype of breast cancer is something that we are exquisitely sensitive to, and it really drives our therapies. Breast cancer care today is very multidisciplinary, as you heard from Dr. Greenup about surgical approaches, and you're hearing from me about medical oncology approaches. However, you are up and center in any care that we give. And then we also rely on a number of specialties, including radiation oncology, plastics, nursing, allied health, and supportive care. And we continue to work on how to personalize breast cancer care. We want to accurately diagnose you, be able to tailor your treatment with the right amount of therapy. We want to manage your toxicities the best that we can. And we want to involve you as patients, as key stakeholders every step of the way. So these are our goals as your guides once breast cancer is diagnosed. So in terms of where we are with breast medical oncology, there is a lot of focus on personalizing therapy, really delivering the right treatment for the specific subtype of breast cancer. Instead of a cookie cutter response, we really want to tailor our treatment recommendations to your specific breast cancer type, as well as your specific preferences and other health conditions. We want to actively manage side effects and toxicities, involve you in the decision making. And part of the reason that we want to do this is that the breast cancer survivors actually make up the largest group of survivors. As you can see on this plot on the left, the growth of cancer survivors continues to increase and is expected to reach 26 million by the year 2040. And patients with breast cancer actually comprise the largest group of cancer survivors. And as I kind of explain these concepts, I thought it would be helpful to do a few brief cases to just highlight some of these learning principles. So example one is a 60-year-old woman who's diagnosed with our most common type of breast cancer, a stage 1 breast cancer that is estrogen receptor positive, progesterone receptor positive, and HER2 negative. She has surgery, just like Dr. Greenup explained, undergoes radiation. And then because her tumor is estrogen receptor positive, she starts one of the anti-estrogen pill therapies through her medical oncology specialist. And generally, this patient has an excellent shot of continuing to remain cancer-free, particularly if she's able to take her prescribed therapy. However, she may still have side effects, no matter how favorable her diagnosis is. One of the things that we actively manage in breast medical oncology is that no matter how favorable the breast cancer diagnosis is, one, it's never easy to be diagnosed with any type of cancer. And second, our medications do have side effects. So she may experience hot flashes, she may experience fatigue, she may experience arthritic symptoms, sexual issues, and may experience weight gain. Or she may not experience any of these. But really what I wanted to explain most importantly from this slide is that any side effects that you're experiencing during treatment, it's really important to report it to your oncology teams. And as you can see by the outer wheel, there are a number of options that we can use to manage these symptoms. Nothing is perfect. However, there are evidence-based approaches that we can use. Moving on to example 2, to give you additional flavor of the different types of patients and clinical issues that we face in medical oncology, is a younger woman who's 45 and is actually diagnosed with advanced or metastatic triple-negative breast cancer. As Dr. Greenup explained, it's really important for the younger patients, or really all breast patients, to have genetic testing. And she's actually found to have a hereditary syndrome known as BRCA or BRCA1 positive. And because of this finding, because of the finding that her genetic makeup is BRCA positive, we're actually able to give her a very specific pill therapy called olaparib that specifically targets this pathway. And I can't tell you how important this genetic finding was, because in several studies, what we found was that these targeted pills actually outperformed. They did better than traditional chemotherapy. For example, the targeted therapy is the burgundy line. So more patients are actually doing better on targeted therapy compared to traditional chemotherapy. So knowing your target can improve how our patients do over time. Similarly, as we figured out, one second, let me tell. So similarly, we found out that also introducing these oral targeted therapies earlier on in early stage disease also improves outcomes, as the International Olympia study showed that giving early stage breast cancer patients who have found to have a BRCA alteration also improve disease-free survival. So knowing our targets, knowing the genetic drivers of the breast cancer absolutely improve outcomes. So we have many more targeted therapies, and these are leading to personalization of care. We are still learning how to do this in the very best way for each of you. And the list of targeted therapies continues to grow each year in breast cancer. And for this particular patient, we were targeting this BRCA pathway with the drug olaparib. However, there are a number of other targets, those that target immunotherapy, those that are specific for triple-negative breast cancer, as well as additional pathways that we can combine with our anti-estrogen therapies. And the list of drugs continues to grow. You're not supposed to memorize the content of this slide, but really my message is how many drugs are really coming soon. We are really at a cusp of several breakthroughs of several important targeted therapies in medical oncology. And what used to be a very simple plot is now very intricate, really targeting different subtypes of breast cancer. So for HER2 positive breast cancer, we have a number of targeted agents. For triple negative, we do as well. And then we're beginning to learn of a new subtype of breast cancers that we call HER2 low. So they were previously classified as HER2 negative, but what we're learning is that even a little bit of a HER2 signal can be targetable with emerging very effective drugs. Moving on to our third case is a 50-year-old woman who's diagnosed with clinical stage 2 triple negative breast cancer. Because it's triple negative and because it's stage 2, it's really important to start preoperative systemic therapy prior to surgery so we can actually gauge her response to therapy. And so given the subtype of breast cancer that it is, she starts chemotherapy plus immunotherapy. And 60% of patients receiving this regimen actually end up having a complete pathologic response. And if a patient does not have a complete response, then we can do additional therapies at the back end. So by choosing to do treatment prior to surgery allows us to further personalize this patient's treatment. In terms of future treatments, we have a number of newer, smarter drugs that are known as antibody drug conjugates. And the idea is that we can link the chemotherapy to an actual toxin linker and actually get it inside the tumor cells more effectively and release the chemo drug inside the tumor cell based on the target. And these are actually, several of these are actually approved, and we are expecting at least 5 additional approvals in the next coming years. And they actually positively impact several subtypes of breast cancer. So we are very excited about these. So in terms of what precision care in breast cancer medical oncology means, we are absolutely looking at more targeted therapies. We're also continuing to be aware that it's not just about the newest and best therapies, but that we need to also improve access and health equity throughout the US and throughout the world. We know that team-based and whole system thinking work best in breast cancer, so continuing to collaborate across all specialties, and the idea of right sizing of therapy. Some patients need more therapy, some people will need less, and I think what we're facing is how can we pick the right therapy for the right patient. And all of these efforts are meant to improve patient outcomes, improve patient experience, and really lead to evidence-based, more efficient healthcare delivery models. And I can't say enough about the oncologist in Torrington. I actually meet with them on a weekly basis, and I've been so excited to collaborate with them. They are phenomenal physicians, and we review the most challenging cases together, and it's really highlights that team approach to care. And I have really enjoyed getting to know them as colleagues, and I can attest to the wonderful care that they're giving patients with breast cancer. And as you heard, Torrington is a convenient location with access to all Yale associated services. My email is listed here, and I'm happy to hear from any patients, and I'm happy to help in any way that I can. I look forward to your questions and to interacting with you in future sessions. Thank you so much.
There is a question in the chat in relation to risks affiliated with the use of vaginal estrogen for dryness or frequent urinary tract infections for patients with a history of breast cancer. ER positive versus ER negative, does that make a difference?
It's a really great question. And what we know is that topical estrogen, the absorption systemically in the body is extremely low, if at all. So what I recommend to patients is definitely try daily vaginal moisturizers and try other non-estrogen based lubricants. And if you're still continuing to have urinary tract infections, pain, irritation, definitely for sure, trial of estrogen local-based therapies, I feel very comfortable with. I think generally many oncologists and symptom-based researchers also feel comfortable with this. Your question of whether it makes a difference versus ER negative or ER positive, depending on your oncologist, they may feel more comfortable prescribing this in ER-negative tumors. However, even in ER-positive tumors, the risk of systemic absorption is exceedingly low. And what I suggest to patients is if the other therapies are not working, try the local estrogen therapy for a short period of time. When symptoms improve, you can certainly cut back and stop.
There is a patient-specific question in the Q&A. I don't know if you can see it, Dr. Lustberg.
Yes. So we have a 2-time survivor who completed 10 years of Arimidex, had a range of therapies. And I don't see the actual question associated with it, but I think what you're highlighting is that there's still many genetic alterations that we haven't discovered. So it doesn't mean that there is not a genetic alteration. However, our current technologies and current databases have not specifically found the specific genetic alteration in your case. So I think what it might mean for your family members is to still take into account your family history, your own diagnosis, and generally we would advise that they would undergo more careful screening procedures starting 10 years prior to your diagnosis. But I think what you're referring to is all the mysteries of breast cancer that we still don't know for sure. There's definitely a genetic alterations, we just are not aware of it yet.
I do not see any other questions right now.
There's one thing. There's a word.
Oh, there's another one coming in.
Oh, it's relating to the clinical breast exam. I think part of this was the confusion on how we were calling self-exams versus a clinical breast exam. So no study has shown that doing like a specific self-exam has found tumors any better. However, being aware of your breast changes is definitely something that we definitely recommend to our patients. A clinical breast exam may be referred to by different providers differently. Generally, a clinical breast exam is done by a clinician. And I think this is something that we continue to recommend for patients diagnosed with breast cancer, that based on NCCN guidelines, they continue to have clinical breast exam by a qualified provider at least twice a year. So I hope that clarifies that question a little bit more. I think that what Dr. Greenup was more specifically referring to was the idea of going in the shower and doing a self breast exam once a month, a week after your period. That just has not been shown to be helpful in a randomized study. However, women do still find their breast cancers and they should know their breasts.
I don't see any other questions coming in. Maybe we'll just wait one more minute if somebody is typing.
The question about namasite radiation. So yes, so this was like a procedure, and not being a radiation specialist, I'll give you the medical oncology general opinion that this was a procedure where more localized radiation therapy was this portal or balloon was inserted into the lumpectomy cavity site, and radiation was delivered in a very local way. I would say that rates of using this modality have gone down. I think with modern breast radiation technology, where we can actually, for very favorable breast cancers, actually deliver breast radiation in a much shorter period of time, I think it has fallen out of favor partly for that reason. And second, I think it can be sometimes confusing in the future to follow breast imaging after mammocyte radiation. It can be harder a little bit to see the lumpectomy cavity changes. So I would say, to answer your question, I think the rates of use have definitely gone down compared to previous years.
There was a follow-up to that. Surgery was in 2009, and the individual's been having rib fractures ever since.
Sorry to hear that. There are so many adverse events that sometimes we're not even aware of when we first deliver some of our therapies. So it's possible that it could be related to that. I would also make sure that your bone health has been more broadly evaluated with bone density, calcium and vitamin D levels, and parathyroid hormone levels, just to make sure that there are not other causes to the rib fractures. But to your point, it is possible that it could be related to the prior radiation, and I'm sorry that you're going through that. That can be very painful.
Yep, 2 more questions in the chat.
Let's see. So I had genetic testing for that was 11. Should I repeat the genetic testing? Great. So this patient had genetic testing 11 years ago. And so what we're recommending is, as genetic testing panels have expanded over time, we are recommending that any patient who had testing prior to 2013, so that applies to you, should undergo, at least undergo a discussion with the genetic counseling team, and more than likely you will have additional genes tested, because 11 years ago they were primarily testing for BRCA1 and 2, however not testing for some other associated genes that we know can elevate other risks of cancer. So I think for your particular case, I think seeing a genetic counseling team would be a good idea. Great question.
Do you want me to read the other one? Given the relative failure of the Cancer Genome Atlas to find straightforward genetic mutations for most cancers, what do you think of metabolic approaches to starve cancer cells as an adjunct to traditional cancer therapies?
This is an area of active research. So in terms of, we are learning a lot about it. In animal models, it's highly, highly effective. So when we metabolically limit food intake, when we have longer duration of fasting in animal models, it does fantastic in cancer models. In humans, the data are a little harder to study. There are data, though, that prolonged nighttime fasting. For example, there was a women's health nurse study that showed that patients who fasted more than 13 hours, and if you think about it, 13 hours is not that long. So if you go to bed at 7, if you stop eating at 7 p.m. and don't eat again till, let's say, 8 or 9 p.m., that's about a 13-hour window. They actually had improved, decreased risk of breast cancer. Now, this was observational, it was retrospective, so the strength of the data was much more limited. I wouldn't necessarily call this starving the tumor cells, but the idea of limiting our constant exposure to metabolic calories, I think there is some biological pathways that could potentially be positively involved. As an evidence-based scientist, I would have to tell you that we still need to generate additional data for this, although if you go online, there are lots of people who are talking about these approaches, including, for example, fasting during chemotherapy and other more radical approaches. So from my standpoint, I would say that there is something to it. We still need to learn a lot about it. And I think our human bodies are so complex, and that I think you're right. Metabolic pathways are part of the answer. But I don't think it's as straightforward as simply starving the tumor and you have your answer. But I think there's definite biological pathways that are implicated, and it's an important question you're asking, and people are actively studying it.
Okay, I don't see any other questions right now. But there were Dr. Lustberg and Dr. Greenup's email addresses have been put in the chat for you. Also, if you think of any other questions after the presentation, you can also email canceranswers@yale.edu at any time. And it looks like maybe we have one more question coming in. Nope, that was Dr. Lustberg's email.
Thank you, everyone.
Thank you guys for joining us tonight.
Bye-bye.
Thank you, everyone.